health and health policy. I'm very, very glad to see some of our CUNY School of Public Health faces back after the summer leave, and it really warms my heart, but it also warms my heart to see many new faces today that I have not seen before. Since we have more than 150 participants, I would like for you, please, to put yourselves on mute so that we don't get any distractions to our presenter today from any sounds that were not intended to be part of the presentation. I'm very, very happy today to present to you a unique presentation about the public perception, global perception of government responses to COVID-19. This presentation is going to be shared with us by a very qualified academic, Professor Jeffrey Lazarus, who is an expert on health systems and infectious diseases, and globally known for having developed the microelimination approach in viral hepatitis C and the fourth 90 in HIV/AIDS. I consider Jeff a personal friend, and he has a broad network within the CUNY Graduate School of Public Health and Health Policy, all of whom welcome him today as I welcome him myself. Jeff serves as the head of the health systems team at the Barcelona Institute for Global Health, IS Global, and is an associate professor at the Faculty of Medicine at the University of Barcelona in Spain, from where he is joining us today. He is vice chairman of the board of EASL, International Liver Foundation, and co-chair of the HIV Outcomes Beyond Viral Suppression Coalition. He's the author of more than 200 publications, including co-authorship of the Lancet GastroHep Commission on Viral Hepatitis, a seminal publication in 2019, and the lead author of the Lancet HIV series, HIV Outcomes, Beyond Viral Suppression in 2019, as well as the new suggested COVID score in Nature Medicine 2020, which probably will be part of his presentation today. He has presented at more than 75 conferences, as well as in the Danish, Finnish, Spanish, and European parliaments. Professor Lazarus is an editorial board member of the International Journal of Drug Policy, HIV Medicine, and the Journal of Hepatology. Previously, Jeff worked for 11 years at WHO Europe and 3 at the Global Fund, as well as serving as the founding director of Health Systems Global and the board chair of the foundation AFEW International. During the current pandemic, though, Professor Lazarus and his team have reoriented their research to address public health and policy efforts targeting COVID-19, often in collaboration with the CUNY School of Public Health faculty. He has appeared as an expert multiple times on the BBC World, Euronews, Sky News, and Spanish National TV. Join me in welcoming Professor Lazarus today, and we are eager to listen to you. We will probably dedicate the last 15 minutes of the next hour to the audience questions. So if you can please make sure that you end the presentation at about 4:45, and I will be keeping an eye on all your questions as you post them on the chat box on Zoom. Welcome again, Jeff. We're very much looking forward to your presentation today.
Well, thank you very much, Dean. Thank you for that warm welcome. It was really just over a year ago that I got to know you and the CUNY faculty, but it was over 20 years ago that I met Scott Ratson when I was working at the World Health Organization and was a bit interested in communication and was told by one of the directors that I needed to meet Scott. And we've stayed in touch over the years and have been in closer touch recently, and he brought me up to CUNY and said, I don't know what exactly you all should be doing, but you need to meet the dean and meet some of the staff. And since you mentioned that I've been collaborating with your faculty, I would just like to acknowledge some of them, because it's been quite a whirlwind year starting already before the pandemic, with quite a bit of collaboration in addition to with yourself and with Scott. We've been working closely with Professor Terry Huang, your policy director, on our projects related to non-alcoholic fatty liver disease linked to the EASL International Liver Foundation. And Terry and I have already published thoughts on how to sound the alarm on the silent pandemic of NAFLD and NASH. We published that in Nature Reviews. We've also published in BMJ Open, and I'm so grateful for Terry's knowledge on communicable disease, an area I'm not as familiar with. I've been working with, or starting to work with Dennis Nash on a new consensus statement to really understand what we mean by a fourth 90, which is going to be paradigm changing within HIV. When we were told how complicated it would be to run the Delphi aspects of the consensus statement and the requirements from Nature Communications, I turned to you and you directed me to Diana Romero, who's kindly agreed to serve as our independent moderator to bring together an unruly group of around 50 experts from around the world who are going to try and get agreement on what we need to do next in the field of HIV. Recently, we've been working with Kasia Waika, your statistician, and I'm going to explain those studies in a moment. They're based on the COVID score study that you mentioned and how we're further developing that. We have a series of papers coming together with the global burden of disease, and you directed me to Mary Schooling in your group, who's going to be working with us on that in order to develop a new score looking at the sustainable development goals and which goals and targets are most relevant for, again, NAFLD and NASH, a serious but really under acknowledged liver condition. Paolo did send me a video of one of the previous grand rounds. So to prep me, I didn't wear a tie like everyone had, although I did wear a jacket. I'll see how long that lasts in the Barcelona evening heat. It's after 10 p.m. here. And the first speaker said, I've known Jim Sherry, for 25 years. I thought, I've known him for 5 years. That's not bad. And it was great that Jim reached out to me. We collaborated on a project. He led a huge USAID funded project called Translating Research into Action. And that's really, what I'm about, what my background is. It comes really from an advocacy background. When I joined WHO, it was an advocacy officer and not a technical officer. And I was told if I wanted to advance in that kind of organization, I needed to get a PhD. I needed to start to publish. And although that's what you highlighted, I find that for me is a bit secondary compared to the kind of action-oriented research that we've been collaborating on and that my team works on here in Spain. I might have left out someone. I'm looking through my notes, but it's been amazing in this year to connect with so many people at CUNY. Let me share my screen here. And get this open and get all the way back to the beginning. Great. And really, you asked me to talk about the research we're carrying out jointly on the COVID-19 pandemic, the role of trust and public perception, and that will be largely what I focus on, and I'll look very much forward to the dialogue with everyone online. I'm a big fan of the evidence that says if you end early, you get better evaluations. So I'll try not to go the full 45 minutes in the hopes that people will enjoy it a bit more, and I'll look forward to the discussions we have. You also asked me to give a little bit of background on what we're doing at IS Global. We're a relatively new institute bringing together a bunch of small institutes. We're now over 400 staff, not all researchers, working on communicable diseases, non-communicable diseases, environmental epidemiology, health systems like myself, and so on. And we're part of various Spanish and Catalan research networks, and we're associated with both the University of Barcelona and the University of Pompeu Fabra. this institute, I came from a clinical research center as being really the only health systems researcher there. I thought I might be able to change things there, but in the end I left and went to an institute that was focused on not just research and innovation, but also policy and global development and education and training. I think very much like the way CUNY is organized. And often we all feel that whichever department you're in is the most important department, but it really is a circle with our researchers teaching and an important component linked to knowledge translation through our global think tank. I put these two images here because on the right, in one of our labs, this is what it used to look like. Now, I don't know if you can see me as well, but I'm holding up the various masks. Now we're all wearing masks, both in the office, on the streets full time, and we can't meet at the labs like we could before. Instead, many of us have turned to writing these kinds of policy briefs that you see here on the bottom right. We've already published 19 informational briefs at the request of the Spanish government because we were hit very, very hard at the beginning of the pandemic in March. New York City followed very quickly. So as a New Yorker, my heart really went out, and I was also very sorry to see how the US did not learn from the many mistakes, but also some successes we had in Europe and in Spain specifically. So the government would ask questions about how to meet children's needs, about how to allow physical activity during a very draconian confinement. Did immunity passports make sense? All of the issues that you've been hearing about, and we would bring together experts and try and write up a very short brief. The one I worked on was how can we ensure a socially equitable approach to deconfinement during the COVID-19 pandemic. It's been deconfinement, it's now turning into confinement again, but I'm very much focused on how do we address vulnerable and marginalized populations, and I'll share more about that as my talk goes on. But let me go back to some of my earlier work, not all the way back to 1957 or even 1998 when I met Scott here at the World Health Organization's European headquarters. I lived just down the street, and the building you see on the right is where the Global Tuberculosis Center started. Back then, TB was the scourge of the world, and they said if you were going to address one global public health issue, it would be TB. And that building eventually grew into the European office of the World Health Organization. And in 2009, my last year at WHO, after a decade there, we were involved in a very different pandemic. If this could be more interactive, and I'm not going to make any attempt to try and poll and interact in the middle of my presentation for fear of never finding it again, but I would ask you, which pandemic, was that? And you can take a moment to ponder, and you might say it was the influenza pandemic, the swine flu. Hopefully you wouldn't call it the Mexican flu. You could call it the novel influenza virus, but how many times can we keep calling it novel, at least in the future? It was the H1N1, it was the H1N1 2009, the swine origin influenza virus. There were a lot of different names going on, and I was charged with handling communications for a while for the Communicable Diseases Department, and being an organization issuing normative standards and guidance, we had to be on top of the evidence, and we found it was extremely difficult to sort out what was going on. There wasn't a whole lot being published very quickly, but it was very difficult to find. So right after that pandemic dwindled out, one of my colleagues and I did a small study to look at the pitfalls of inconsistent naming and the effects it can have for health experts on obtaining relevant scientific information. In a nutshell, basically it meant that if you were searching for the wrong words and you didn't have a comprehensive search string, or if the articles weren't being indexed with all of these different names, you'd miss key evidence. And we kept seeing people cite the evidence and then others cite different evidence, yet it was on the same specific topic related to that pandemic. So we did a historical search through the first 10 weeks of the H1N1 pandemic, and I won't go through it all here, but basically you see that depending on which term you don't include in your search or in the index, you get a different number of hits. Back then, and I'm going to later conclude my study showing you when we repeated this study for the current pandemic, what it looked like, but we went through every missing article and was able to skim or even read them to see if that evidence was at all valuable during those those first 10 weeks, and what people were actually missing and how that impacted policies at that time. And we concluded that due to this inconsistent naming, while searching for scientific material about rapidly evolving situations such as the influenza AH1N1 pandemic, there's a risk that one will miss relevant articles. And we made a simple conclusion that we should agree on nomenclature and the scientific name to be used earlier. And that's something we've seen with the current pandemic, agreement on a name rather early on in the pandemic, even before it was announced as a pandemic on March 11th. So the crux of my talk is really around the central role of communication and trust. So many actors in the response to the COVID-19 pandemic are holding out for a vaccine to be developed. But in the meantime, tried and tested public health measures for controlling outbreaks can be implemented. This was more or less the same thing we said in 2008 when we thought we might have an HIV vaccine in hand, and we went to the International AIDS Conference in Mexico. And while everyone was talking about the vaccine, we were lamenting at the European Office of WHO, hoping for the vaccine, but lamenting that basic HIV control prevention measures weren't being implemented by most countries, whether it was harm reduction measures, scaling up testing, scaling up treatment, so on and so forth. So we wrote an article about that. Unfortunately, there has been no vaccine developed for HIV. And while thinking about that and tweeting about that, I was contacted by the Nature family of journals, and they asked if we would write something up about that. And I said, well, you know, we've been focused on vulnerable populations. We're right in the middle of the pandemic, but let's give a thought about what we could do. And that's when I connected with Scott. Scott connected me again with you, and we brought together a group of experts, you know, really from around the world, including the former European Commissioner for Health and the former Minister of Health of Rwanda and others, to brainstorm, you know, what that would be. The response to COVID-19 has underscored the need for governments to improve their outbreak preparedness and response by incorporating what I think is a health systems approach. And first and foremost, that means improving public health communication and health literacy. So an outbreak cannot be controlled without broad public support. Clear and consistent communication to the public via reliable, comprehensive, and up-to-date data is vital for effective outbreak control, and explaining the basis for the latest public health recommendations, particularly in the context of a novel virus for which new evidence continues to emerge and guidelines continue to evolve, will be critical for building trust and encouraging compliance with the recommended measures. So that was all the kinds of summing up the discussions we had as we started developing the COVID score. But let me just take a step back. You know, when I say a health systems approach, I'm really thinking back to the framework that Tim Evans, and I know some of you have worked closely with him, developed when he was an Assistant Secretary General for Health Systems at WHO back in 2007. And his group said that, you know, the system is really made out of six key components: service delivery, the health workforce, information, medical products. They specifically called out vaccines, technologies, as well as financing and leadership and governance. And there were these interim goals, what I call the public health challenges of access, coverage, quality, and safety, all key issues we're facing right now in the pandemic, but often we address them as if it's a big surprise, issues around quality and safety of treatments in the pipeline, of vaccine development and access and coverage to basic tests, so we know how many people and who has COVID-19. And the ultimate goal of any health system, as defined by WHO, first and foremost, is improved health. And because it's WHO and because I was there, I can criticize it in a friendly way. No one could agree on what improved health was, so they added in these parentheses and said it's level and equity. So it's not just about reaching certain targets like reductions in the number of deaths, the number of cases in your emergency room beds, or the number of cases in your country per 100,000. It's also about equity. We really can't leave anyone behind. So we need to measure all of those levels at a national level, at a subnational level. In your case, you've been measuring at the city level, but also through the different affected populations, be they more marginalized populations like certain migrant populations, people who inject drugs, sex workers, and so on, or vulnerable populations like the elderly who have been so affected throughout this pandemic. Now, I think this is a great framework. I think it's missing some elements around how to engage with the population, around communication. So in 2014, Tim France and I, while I was at Health Systems Global, we put this out to a public discussion, and the consensus was don't change anything, but you can, or don't remove anything, but you can add a little to it. So we added communication on the left and patient engagement. That later fell away because people said it's not just about engage, the health system shouldn't just engage with patients, it should engage with the entire population, because one of the goals of the health system is to have fewer patients through good health promotion. WHO picked that up and ultimately came up with the people-centered health systems approach. They put the people in the center. They turned those building blocks into a circle in order to show the dynamic interaction between all of the different parts of any health system. And I think if we had a lot more time, we could be analyzing each of these and saying, well, where has been the breakdown in our response to COVID-19? We've had issues around the workforce. We've had issues around financing. I will not go down the road around the issues around leadership, but there have certainly been some major leadership, governance, information service delivery issues, not to mention all of the challenges with the medical products, including the recent setback with the Oxford vaccine that was just announced, and even some questions around the data that the Russian research group provided to the Lancet. But importantly here is people are at the center. And how often during the pandemic have we been asking the people what they think, what their perception is of the response? So that's what we set out to do with COVID Score. Here, just emphasizing again that when we have a pandemic control strategy, we need to take account of the varying educational, cultural, language backgrounds so that all population groups are engaged. One tool we developed and that came out just before the pandemic, but that I found useful, and I'm going to show you some data from a study we just carried out, partly using this, has been a service design checklist. This checklist was developed and published last year to look specifically at, it's called Nobody Left Outside, so specific marginalized populations and their involvement with different aspects of the health system. So if we zoom in, on this 6-part checklist just to look at service delivery, we would ask questions like, were community representatives involved in the design of the services? So when the elderly were being sequestered, when they were being confined in different countries, did we ask them how they want to be treated, or did we do what we thought was best and look at the problems that came out of that? Other design considerations, and we are redesigning our services quickly during the pandemic, are thinking not just about the health, but also the social care needs of the community, existing and new barriers to services and access for the community, and looking at the resources and skills that we actually have in the community. And that's one of the things that's impressed me so much about CUNY, being based in a community setting and focusing so much on the community around you, as well as being, a global health institution. So taking this background and going forward to COVID Score, we wanted to think about what would a whole of system perspective be? How could we best understand public perception of government decisions and actions so that they can inform the response efforts? And what might impact on public perception? So what socioeconomic, demographic, political factors, including the issue of trust in government? Would trust in government in general impact on the public perception of the government's response to this pandemic? And we thought about, what are the sources of information for any decision maker? I'm in Spain, where we have 17 autonomous communities. So we need to think about subnational governments. You have the same issue in the US with all of your state governments. The role of scientific advisors and researchers that's often been brought into question during this pandemic, and the role of tech companies and the compromises people might be asked around privacy in order to get the big data we need to address the pandemic. The role of media, non-governmental organizations, and public and citizens. All of this feeds into decision making, and we could really only address a small part of that by focusing here, at least, on the public and on the citizens. So we agreed on 19 items to assess public perception. We also agreed that my idea of 19 wasn't a very good one because we wanted a score out of 100, and the math is complicated with 19. So question 4 is A and B. So we actually have 20 questions, but I did like the idea of 19 items for COVID-19. We wanted to focus on issues around, has there been clear and accurate communication with the public? What's been the access to COVID-19 testing and treatment? The continuity of health services, including specifically mental health services, social protection, and assistance to meet daily needs. I realize you can't read all of the questions here. I'll come back to them later, but this gives you an idea of how we designed it specifically as a scorecard so people could rank the responses. We implemented this in 19 heavily affected countries. You can see them on the right, a little geography test. We worked with Emerson Polling, who CUNY's been partnering with on your weekly surveys in the New York context. So we were able to have strata established by age and gender and level of education and region. In order to get a representative sample, we had around 700 per country, over 13,400 total. So an incredibly rich data set that we've been analyzing very intensely since we collected data on the 20th of June. And I would actually, since one of them just popped up in the images on my right, acknowledge that some of the key collaborators from CUNY are on this call, and your support's been fantastic. So thank you, Scott, Ken, and others. So we also realized that 19 questions were a lot and we needed to move quickly. So we reduced it to 10 key questions we determined were key. And we asked each individual to respond if they completely disagreed, or 5 completely agreed. We used a min-max transformation to get a resulting score of a range from 0 to 100. And you see them over here on the right, listed in alphabetical order. But starting with Brazil, that scored just 36 out of 100. It gets better when you go to Canada, it gets better when you go to China, maybe no surprise. And then it drops off massively with Ecuador. Look at France scoring under 50, and you can look for the countries that interest you, but we tried to make sure that we had heavily burdened countries, but also geographic representation. We'd love to be able to do this in 50, 100, 150 countries, but we started with these 19. And while some countries are scoring much better than others on the public perception of the government response on these 10 key items, really no countries are doing very well, although you might argue that China's 80 is well, but we also have to question how freely people will respond in certain settings. And I will come back to this a little bit later. We looked at the country score heterogeneity among the demographic groups, gender, education, age, and income. We didn't find that much of a difference within the countries, but we did find differences among the countries, as you can see here, and I won't go through that. The paper has just been largely accepted for publication, so we hope that will be out in the next couple of weeks. I would like to say days, but the journals are moving a bit slow again. And one of the parts of this study was actually to validate the COVID score tool itself, and we found a high Kronberg's alpha score that showing that there was reliability, there was unidimensionality. We also ran some external validations looking at univariate regressions between the country score and various variables broadly representing socioeconomic, demographic, and political factors, including trust in government. And you can see those listed here and some of the sources we use, like the World Bank for socioeconomic income, like the Economist Intelligence Unit's Democracy Index, the HDI tool, and the Trust in National Government study that the Wellcome Trust ran. And there you'll see that we found that we could externally validate some of these variables, and specifically and importantly, a key finding was that general trust in the national government and trust in the government to successfully address unexpected health threats were clearly associated with country scores for COVID score 10. And I think we'll come back to that because I know there's a lot of interest in understanding trust and improving trust, but we found that that association held specifically for our study. So at Scott's request, we tacked on a couple of questions around vaccines, and these have already been presented at a Wilton Park event through the Convince partnership that Scott and Heidi Larson are leading. So we didn't publish them together with the COVID score. It's been submitted separately, but we asked the question of, if a COVID-19 vaccine is proven safe and effective and is available, I will take it. Here you see the scores ordered by number: China, Brazil, South Korea, quite high. This falls off with countries as diverse as Nigeria, Sweden, France, Poland, and Russia to your far right. Scott and others can speak better to what it will take to have herd immunity, but if the numbers are 70% or 80% of the population vaccinated, we have a long way to go. There will also be a gap between those who say, I will take it, and those who actually do take it, because of all of the challenges we'll face logistically in rolling out such a vaccine. We asked a second question: I would follow my employer's recommendation to get a COVID-19 vaccine. So when asked if an employer's recommendation would lead to vaccine acceptance, we found some shifts in the sentiment can be seen. So China remains in top agreement at 86%. South Korea shifts up to second place. Brazil drops to 66%. France, Poland, Russia remain in the lowest percentages of agreement, but Sweden slides down the lowest levels of acceptance to 45%. I'll give you a minute to take a look at that. So some of our other findings were that globally higher scores were observed for the perception that the government was cooperating with WHO and other countries and produced accurate reports and statistics. Lower scores were observed for items assessing mental health service provision, protection for vulnerable groups, and assistance meeting daily needs. And items which performed near the average assessed continuity of routine health services, free access to COVID-19 testing, and government communication about the pandemic. And so what can we do with these findings? How do we make them action-oriented? Well, it would be nice to have a longitudinal implementation of COVID score 10 so we could measure variations in public perceptions as a country's epidemiological trajectory and response strategy changes. That's what I have to say as a researcher. As an activist, I hope that government decision-making will look at integration of community perspectives in the policy design and implementation processes, identification of possible obstacles to achieving disease control objectives, and exploration of the trust relationship between the public and their governments in pandemic mitigation and control activities. One of the big challenges we've faced, whether you're in Barcelona, New York, or so many cities around the world, has been general health service disruption during COVID-19 and what to do about it. So as countries swiftly, or in some cases not so swiftly, implemented disease control measures like physical distancing and confinement, health providers often had to adapt service delivery patterns with little notice and under great system stress. And individuals have been required to adapt their health seeking and utilization behaviors. Vulnerable groups like those with multimorbidity, living with HIV, group I'm focused on in my research, or who use drugs, have been put at increased risk. WHO did survey 105 countries on 25 essential health services. They found that 90% of countries experienced some disruption. Actually, I'm wondering now what the other 10% that didn't are, but 70% saw immunization disruptions, NCD treatment and diagnosis disruptions, 61% saw mental health treatment disruptions, a third saw antiretroviral therapy for HIV disruptions, so on and so forth. So no big surprise. The question is what do we do about it? And what have those disruptions resulted in? In the European setting, the European AIDS Treatment Group ran a small survey among its members and reported that they need more psychological services, that harm reduction services had been affected, that there were challenges around reporting and addressing gender-based violence. There were reports of postponed HIV services, including viral load testing, HIV testing, STI testing, and changes related to HIV medicines. So the EATG really sounded the alarm that the COVID-19 pandemic is going to roll back gains made on the HIV and AIDS pandemic. We quickly responded with a small study in Spain where we surveyed 20 harm reduction service providers. Many of these harm reduction services in Spain are actually closely linked to social services, mental health services, and infectious disease testing, in addition to the traditional harm reduction we're familiar with, like needle and syringe exchange or opioid substitution therapy provision. So we had a structured survey administered to focal points in these centers to look at the impact of the pandemic in 4 of the 17 autonomous communities, the Basque Country, Catalonia, where I'm now, the Madrid region, and Sevilla. And we compared the 2020 period to the 2019 period. It's a bit of a crude measurement, but we wanted to move quickly. We had 11 centers respond. A few more have just trickled in after the August break. 100%, all 11 reported adapting their services to meet demands and stay open. 1 center shut down completely, 4 reduced their operating hours, and to my great surprise, a couple actually increased their operating hours. So it's not always bad news, and that's what research can sometimes inform us. Overall operating hours, however, did decrease in 2020 compared to the same period in 2019. HIV, HBV, hepatitis C, and TB testing varied by site, but decreased, I think, rather drastically. The message in Spain was stop testing for new infections. Our hospitals are overwhelmed, so it's not going to do any good to be sending patients who are newly diagnosed with any of these infectious diseases. My sense is that this has been a message in many, many other countries, but now we have the data to show this from Spain. In response to the question of how do you evaluate the response of the administration responsible for the prevention of the effects and risks of the COVID-19 pandemic for people who use drugs, you see 40% below average, 30% at average, and the rest, a small group, excellent and above average. And I won't go through, in the interest of time, all of the data, but I think we have a rich data set. The top 5 issues ranked by respondents on the most important challenges faced by people who use drugs during the long Spanish state of alarm that extended from March 12th to around June 21st was limited access to social workers, difficulties with the police while on the streets, an increase in mental health issues, limited access to drug checking services, and limited access to medical services in general. So some of the conclusions we have were that harm reduction services have been able to continue operating and offering services by adjusting their hours. Overall, service users and needle distribution fell. So we think there were fewer clients accessing the harm reduction services. And our main conclusion is that we cannot forget this vulnerable population. One of my biggest fears is watching how this pandemic moves to become a disease of poverty that's particularly affecting vulnerable and marginalized populations who already have a tough time and are now facing an even tougher time and moving forward very much risk being left behind. So I realize I have just about 5 minutes left and a very packed presentation. So I'm just going to go through a couple key points. A lot of people have been hailing telemedicine, what I call telehealth, as a way to resolve the disruption of services. If we can't get to the services, hopefully we can get to a telephone, a smartphone, and contact our services. There's been so many challenges with that in Spain, including the lack of electronic medical records. But we do know that telehealth and telemedicine have big benefits, but there's a lot of questions we need to ask, and we're going out now to conduct a series of over 400 face-to-face with our, I don't know if you can actually see me on the screen, but with our masks on, to speak to vulnerable populations, to ask them questions like, and you can think about this in the audience, where do you prefer to go to healthcare? Do you want to go to a hospital or clinic? We've seen that during the pandemic, and what we thought might have been after the pandemic, although it's come back very quickly in Spain, and even in Denmark, there's been a real fear of going to hospitals and clinics. Some people would prefer to go to community care centers with a fixed location, or community care centers that are more mobile. I have about 50 of these questions. I'm going to ask just 2 here. One of them I think is extremely important, is the issue around privacy. So we're asking, I have access to a private space where I can take calls or videos. This is really important, depending on your condition, depending on your amount of self-confidence. A lot of people with HIV, a lot of people who inject drugs don't have access to private spaces and will not feel comfortable discussing with a care provider in the absence of that. So this closure of services has been quite a challenge, and moving ahead, we need to remember that telemedicine will not be the remedy to all of these problems. We'll ask questions around what innovative solutions providers have been quickly implementing to reach vulnerable populations, how providers and policymakers can ensure care monitoring for those with chronic conditions, and how can providers and policymakers understand the pandemic needs of vulnerable populations, in particularly, be they the elderly or marginalized populations that are difficult to engage with. And here it's extremely important that in some of our countries we have strong NGOs and community organizations, but in many countries these organizations barely exist. There's been a very high volume of pandemic-related research. This goes back to what I mentioned in the beginning when I said that my colleague Ola and I were actually able to read every article that was missed in the different searches during the first 10 weeks. I called up Ola, who's now, was my intern then, is now heading a research center in Denmark, and I said, we should do the same study. And it was really, I think, like week 6 or 7. We said, maybe we can even do the first 10 weeks by the end of the 10th week. And we started, and he just turned and said, this is hopeless. There's 300-400 articles coming out every single day. We're definitely not going to be able to read them all. We need to think about what's interesting here. And we realized that the rapid publication of scientific articles was actually what was interesting. How long would it take a publication to go from submission to acceptance? And you'll see from our title, we believe that pandemic publishing poses a new COVID-19 challenge. We looked at all of the COVID-19 publications to the best of our ability with a strong search string. And I'm going to come back to that issue of the search string in my conclusions. But first, we focused on the speed of publication. We compared how quickly COVID-19 publications were being published. Again, if I could be more interactive, I'd ask you how many days, but you can write it down on a piece of paper and hold it up. But what would be the median number of days from submission to a journal to acceptance? I know there's a couple of journal editors and chief editors in the audience. You might be surprised by how quickly it's gone. We compared that to Ebola, another epidemic, to cardiovascular disease, with the GBD had determined was the leading cause of mortality globally. The answer was, and you can see here on the left with the circle, 6 days during those first 10 weeks from submission to publication. That's the median, not the average. For Ebola, it was 15. For CVD, it's 102. And then we compare it to the same journals in earlier periods and so on and so forth. And you can see this article online in Nature Human Behavior. they thought this was an interesting finding, particularly some of our recommendations about establishing new journal editor standards for maintaining quality during large-scale public health emergencies. We published this before the Lancet and New England Journal retractions of major studies, of which some of my colleagues were involved in pointing out to them around the issues of ivermectin and so on. Requiring peer reviewers to be adequately trained. I think this is really important, and it was a reminder to myself that so many people don't go through peer review courses or refresher courses, and that's important for the journals to prioritize. The importance of maintaining strong curated literature databases, working closely with, the U.S. National Library of Medicine, PubMed Medline, but also Publons and the WHO COVID-19 Global Literature Database, and Hopkins in particular, who have been leading these efforts. And some of these include private companies, and we shouldn't need to rely on private companies to be curating our evidence base. And we need to, I think, the researcher and me speaking, to commission and publish more scoping, narrative, and systematic reviews. There's just so much material coming out that we do need teams and collaboratively across centers to be reviewing critically the evidence as it comes out and publishing that as new sets of evidence. And finally, the study that I mentioned in the beginning during H1N1, we tried to repeat this. And we were looking at, how sensitive would our own search string be? And in the middle of that, PubMed and Medline announced that they were going to have a single click, and you could find all of the COVID-19 articles. So we were about to pull the article until we actually analyzed their single click and found that even that was missing many articles. And one of the major issues we found was, the old adage of, dot your I's and cross your T's, that if you had a space instead of the hyphen between COVID-19, or you combined COVID-19 into one word without the hyphen, you would get a different number of results. So this is, I think, rather disappointing, because I think when we search for COVID-19, we search one way or we search the other way. Most people don't put in the hyphen, put it together, leave a space, etc. So again, just some messages back about how difficult it is to access the evidence base and to find reliable evidence. Let me just close by acknowledging everyone who was involved in the original COVID score team listed here, as well as some of the members of my team who have helped with the long nights and days working first on the COVID score scorecard, but then on our follow-on articles. I presented some of the data from the first article that's now accepted pending final revision in PLOS 1, the second article that focuses on vaccines, and a third article that we're developing now, and had a good call with colleagues at CUNY today as we move forward to even better understand the results from those 13,400 participants on the public's perception of the government responses to the COVID-19 pandemic. So Dean, let me end there and hand over to you to manage some questions and answers. And thank you everyone for listening. I think I did not get under 45 minutes, so I hope that doesn't affect my evaluation. You're on mute.
And there I am, unmuted. Thank you so much, Jeff. This was so interesting. I've been exposed to some of this material already, and looking at it again with an outside eye gives me insights perhaps that I've not had before. The question that comes up is, so what? We are aware now that people respond to their governments in different ways. It seems to be perhaps regionally or culturally motivated. People in Asia seem to be very comfortable, very happy with their government's response. People like the French and the Poles are difficult, and they're very critical of their governments, let alone the Russians, or to our surprise, the Swedes. With these cultural inferences of how people respond, what do you think that these perceptual studies truly mean, and how can they be helpful in the future?
Thank you. I mean, of course, we need to understand the context, be it socioeconomic or, as you pointed out, culturally and socially. But still, I think it points to the central role that trust plays and the role that we need to play as researchers, as advocates in building trust. Trust in the evidence base, trust in the peer-reviewed journals, trust in our leadership, and that includes the World Health Organization, the United Nations, and other organizations that are leading at regional, national, or international levels, so that we can focus on the proven, evidence-based, tried and trusted control measures. Much of what we need to do, and it's a great surprise to me that we're not able to do that, is well known and it's quite easy. I mean, in Spain, in Spanish, we call it the 4 M's, but it's masks, meters for physical distance, manos for keeping your hands clean, and then más or more, depending on your particular context. And I mentioned how so many people, had been responding in our Spanish survey about difficulties with the police. So I might even add multas, which has been one of the big challenges here, the fining of people. I've been watching and getting reports regularly. It's not just, one or few isolated cases of people alone walking down the street and suddenly the police come and they give them a fine for not wearing their mask. And so people have concerns about the authorities, concerns in their response. And yet, we've seen the anti-mask movement starting to rival, I think, even the anti-vaccine movement in some settings. And yet we know these tried and trusted control measures work. So we need to build trust, and we need to show the other countries where there is lower trust that these measures can work.
Another question relates to sustainable changes. You talked a little bit about clinics being responsive, extending their hours, and at the same time you did talk about groups, vulnerable groups, being particularly impacted by the methods of communication and the availability of services. How can we change these lessons learned into sustainable changes that can perhaps inform the future of care delivery?
Yeah, I think it's shown us the importance of community-based groups and of non-governmental organizations in working with marginalized and vulnerable populations. I think we've seen that telemedicine, telehealth is here to stay. It's been progressively gaining traction, but now in some settings we've moved completely to telemedicine. Now we need to start assessing what's working and not working. In that, and I think what's not working is how we reach the marginalized populations who don't always have a phone, a stable internet connection, private setting, so on and so forth. So, so I think it's given us a chance to move quicker to the future. I was reading a report that said, in 10 or 15, this is from just 2 or 3 years ago, in 10 or 15 years, people living with HIV won't even need to go to the hospital. They'll just see their doctor online, have their vitals, using Fitbits and other wearable devices, the doctor will be able to assess them. We thought 10 or 15 years might be realistic. Now it might be, 1, 2, or 3 years, but we also need to realize that it's not one size fits all. This is not going to work for everyone. And I think of Abraham Verghese's great video about the doctor's touch and the importance of that face-to-face encounter, looking each other in the eyes, what you can learn from a handshake. And I think we can't completely ignore the importance of that kind of contact, but moving ahead, there'll be much less of it, I think.
One more question regarding the findings. You chose to approach 19 countries around the world. We are thinking that a pandemic such as this can have a dual effect. We're beginning to see some nationalistic movements, isolating countries, country borders. You live in Europe, the European community. I see you shuttling between Spain and Copenhagen like people shuttle between New Jersey and Manhattan every day. So I want to hear your perspectives as to whether this the pandemic is going to pull people apart or bring people together. And if there's any evidence, at least in the European region, where there's an infrastructure that could be used in either of these two directions.
That's a good question. It starts to get into the realm of some speculation, but I'll try and base my response on what I've been experiencing and seeing, and others are welcome to weigh in. But I think at the beginning in the European Union, it definitely tore us apart. We worked decades to put this union together, to bring in neighboring countries. And the first thing that happened was some countries closed their borders, others didn't close their borders. None of the coordination that's been set up, and there is great coordination through the ECDC, which is the European Centers for Disease Control. There are mechanisms through WHO's pandemic focal points. Every country has a focal point. They get regularly updated when a state of emergency or a pandemic is declared. So there's no excuse for saying we didn't know this and we didn't know that. WHO was in regular contact. They've made their mistakes, and that's another discussion, but the communication was very much there. And it was in Europe, but countries reacted single-handedly and often in isolation. We then saw Europe start to come back together and say, well, we will open up the Schengen area, which is an area we have without borders. We will start to take decisions jointly. And then suddenly we had countries again saying, well, you have too many cases in Spain, we're going to close the border to you, or we're going to at least say you need to quarantine for 14 days, which is effectively closing the border, or our own citizens, when they come back, will have to quarantine, which means no one's going to want to go, this summer to your beaches for tourism and so on, which sounds like a nice, let that be the worst that happens during a pandemic, but it's also 20% of the Spanish GDP. So it's been absolutely devastating here. And this has happened quite unilaterally, and maybe it needed to happen in the end, but it didn't happen through the mechanisms we have. So Europe has been sort of ebbing and flowing in its ability to collaborate. There's other parts around security that I'm not so familiar with that I understand are collaborating quite well, but we do hear of a number of countries going it alone. And I mean, I'm an optimist, and I believe that if you go it alone in the pandemic, you're not going to get very far. A country like Norway can maybe close its borders, but they're also exporting. So, I mean, it is a globalized world. We don't need to repeat that. That's why our institutes are institutes of global health. And so for a little while, you can fight off the pandemic, but in the end, your economy and I think your population will suffer if we're not working on this together. We've seen that already with the, who's collaborating on developing new treatments, who's collaborating on developing a vaccine.
Yeah, I agree with you. I think, Jeff, that once the vaccine is available, a question of global collaboration is obviously a very important aspect of success. We had a guest from Canada earlier on who had a question. I want to make sure that his question has been answered. I don't know if he's still online. You can unmute yourself if you're still online and ask your question. I'll give you a second. Okay, I don't think that there is any more questions to be asked. And with this, I'd like to thank you so much, Jeff, for participating. I'd like to remind all participants today that our next grand rounds will be on the 23rd of the month. You will receive an alert. All participants today will receive an alert with the details on the presentation for that day. We are very, very happy that you chose to spend your afternoon with us. To our new students, welcome to the CUNY Graduate School of Public Health and Health Policy. I hope you enjoyed your first grand rounds. Definitely, this was a very interesting topic. Thank you again for your expertise and for giving us your time and for staying up late just for us, Jeff, in Barcelona. This is the formidable advantage of our grand rounds now. We are getting people from around the world to participate with us, and it's a true pleasure to see you with us today. Hopefully with new information you will share with us, and thank you so very much. Greatly appreciated. Bye to everybody, and see you on the 23rd.
Thanks again.